Good morning. I haven't heard myself on a mic in a long time. I want to welcome everybody. Thank you for the first breakfast series of the Health Cities panel discussion. My name is Shaneel Pathak. I'll be your moderator today. And I want to first off introduce the panelists. And I'll start with Danika. Sure. Oh, yes. Sure. Oh, I jumped the gun.
Shaneel's really serious and he wants to get going on this conversation because there's a lot of ground to cover. So we'll get the fluff stuff out of the way really quickly. Greetings, everyone. Thank you so much for making it out this bright and early morning in Calgary. My name is Reg Joseph. I'm the CEO of Health Cities. Really pleased to be hosting our first Health Cities breakfast in Calgary. Love the turnout for everybody that came this morning. It's really great. Just going to do a quick little land acknowledgement and then we'll move on. We are gathered here today in the traditional territories of Treaty 7 nations in southern Alberta and the Métis Nation of Alberta, Region 3. Health Cities recognizes Indigenous communities in our work and emphasizes the crucial role Indigenous peoples have always and will continue to play in exploring and leading health innovation. Sponsor acknowledgement. This breakfast series here in Calgary is sponsored by Dynalife. So I want to thank our sponsors, Dynalife. As well as a number of partner shout outs. Most of these organizations are here today. So we have Thin Air Labs, Plug and Play, Startup TNT, Creative Destructive Labs, Alberta IoT. Thank you all for your support. Thank you all for being here. Also want to thank a number of our friends that came in from outside of Calgary. Thank you all for your support, for making the drive down and joining us here for this event. Just quick little housekeeping, cell phones on silent. Please take calls outside if you must. Networking will start at 9 and we'll have the place until around 10. Also want to thank Rooftop for this lovely venue. I've never seen it in the morning. It looks just as great. This is wonderful. Also want to thank Chantel and her staff for all the help that they provided us this morning getting this going. So thank you all for being here. And now on to the smart people.
Thanks, Reg. So welcome. We haven't started yet. But let me first introduce the panelists and I'll let them shed a little bit of light of their backstory. And then what I like to do is I'll talk a bit about why I'm passionate to be here and learn from the panelists on personal data. We have a few questions, and then we'll open up to the audience and love to have you be engaged in the conversation. So maybe I'll start with Danika.
Test, 1, 2, 1, 2. Can everyone hear me? Yeah, beautiful. Hi, everyone. My name is Danika. I'm one of the co-founders and the CEO of MyNormative, a female-focused health research platform.
Hi, I'm Maria Savidov. So I'm the manager of analysis and evaluation at Bissell Center, which is a nonprofit organization aimed at eliminating poverty in Edmonton. And over to you.
I'm Gena Rotstein. My company is Karma and Sense, and I'm also the project manager for Converge Mental Health.
And maybe I'll start off with some backstory and the power, and personally how I found the power of personal health data. Some of you know a long time ago, I was 36 when my late wife, Hang, was diagnosed with late-stage lung cancer. We got into the world of information chaos, and I took my management consulting skills, because that's the skills I had to become, in essence, the chief caregiver. And what we did was I would organize our circle of care into a board of advisors. They're at the table, and my job was to collect this data, be it self-reported data, medical reports, or or also information, and give it to the right person at the right time in order to make the right decision. And that helped us improve the quality of life, and also change her prognosis from 4 months to live over 4 years. So fast forward to today. It was that experience. I became a co-founder of Zamplo, and we're building a connected health data platform, a global connected health data platform for this exchange. I've taken, I'd say, grief into gratitude. So I did a lot of work. Moving forward, I recently got married, fell in love. Sarah's here. So things can really change when it comes to getting with the power of data, not just personally, but also for the system. And so that was a context and why I'm very inspired to be here. And I thank you all for attending this event. I'm not an early riser, so I had my coffee. That set the stage for talking about our first question. So let me set the stage. When we had our prep call, I had a list of questions. As Reg knows, I'm very structured and organized, and my first question had to do with how are you empowering people with personal health data? And that caused a lot of debate between us. And it really opened my eyes because I had this wired perspective of what health data is and what empowerment is, and I want to take a step back and really get the opportunity to redefine it and share what other people's perspective is. So I'll start with Maria, please.
Absolutely. So, am I good? Okay. So when we say personal health data, what we usually picture is blood types, diagnoses, all those types of things. But when we were talking about that the other day, I wanted to challenge that and break that open a little bit. During the COVID pandemic, it became impossible to ignore the horrible conditions that the folks experiencing houselessness were living under and the impact that was having on public health. Housing as healthcare became a really critical concept and lens through which we were looking at how we're going to impact our community. So yeah, now that I've broken open the question a little bit, to actually answer it. So one of the things that we collect at Bissell Center is referral data. So we help our community members navigate different systems. We'll refer them to doctors, psychiatrists, supportive housing, income supports. And one of the things that what we track is how long does it actually take from the time of initial referral to when they finally get the service. And a lot of the time, it takes quite a while. And so we take that data, we look at it in aggregate, and it helps us drive decisions around how we can both pivot to provide better, faster services to folks and also advocate to fill those gaps in services and systems that exist.
Thank you, Maria. Danika, can you give your insights on empowerment? What does that mean to you?
Yeah, so I think maybe where we'll start is Shaneel has very politely said a version of the story that's not quite true. So basically he came onto the call with 3 very, I think, powerful, opinionated women and was like, I'm open to constructive feedback. And we were like, the question is fundamentally flawed.
Okay, that's the truth.
And so he was very gracious in giving us the space to kind of deconstruct that. And I think one of the things I'd like to touch on is empowerment and maybe a fun way to start this conversation, maybe give you homework right out of the gate, which is anytime you see an organization say, we empower people too, you should have a giant yellow flag in your hand because you cannot empower people fundamentally. That is not something that can be done. Empowerment is something that needs to be intrinsic and built in. And so it is very important when we think about empowerment to think about if we build a piece of technology or a system or a protocol that only as long as that technology, system, or protocol exists can that person change their life pathway that is not empowerment. You're not actually providing power, because you can't, to that person to change what's happening in their circumstances. And so when we think about empowerment from a lens at MyNormative, we think about dominant discourse, so the way by which we talk about and think about ideas. And so MyNormative's job is to provide a space and a software solution in which we can enable people from all different kind of stakeholder positions along the health sciences pathway to think about something differently and to talk about something differently. And then specifically on the user end, the outcome of that is that somebody then has the agency to pick from things that they think and things that they know and things that they know how to talk about now to then self-advocate for better health outcomes. It's a really, really important kind of distinction for me. MyNormative does not empower anybody, but man, do I hope we hold space so that they can empower themselves.
Thank you, Danika. I wish you were there, because when I met the candidate for our provincial elections, so I met our local candidate, and I talked about data and about empowerment, and the candidate said, well, it's a bureaucratic thing, right? They consider data as a bureaucracy, as a process, not about actual hand the data to the individual, because that's what I'm inspired about, and how it could actually help liberate. So that's too bad you weren't there. I would have, it's like, what's my rebuttal? That would have been the perfect rebuttal. And so one thing we noticed in Canada is the primary factors that shape healthcare of Canadians, or the health of Canadians, is social determinants of health. It's not medical treatments. So Maria, your organization sits in between the intersection of social services, health, and community. Can you explain what social determinants of health is and how you use that type of data?
Absolutely, yeah, I'm so glad you asked. So social determinants of health are anything that is health related, but not necessarily, something like blood type or diagnoses, or related to specifically your physical body. And at Bissell Center, we have been on a long and exciting journey of measuring our outcomes and impacts on folks and using social determinants of health for that. So the tool that we're using is the self-sufficiency matrix. It's being used across different contexts and agencies in academic and social service agencies across the world, Holland, US. And so we are using a version adapted to our specific needs, and we're measuring 6 different domains. So physical health is one of them. We also have mental health, we have support network, employment, housing, financial well-being, and we have another one. Did I say 5? I said 5, didn't I? Well, I will come back to that. Okay, so anyway, so we use all of this data to look at how folks are progressing in their journey from poverty to prosperity and how they interact with each other. Where do demographics come in? Where do program outcomes come in? And this gives us a very rich data set that we're able to then use to drive decision making, to tailor services and to improve outcomes for our communities. One thing that we're focusing on right now is actually housing retention. So we just did some really interesting analysis. We got some really interesting analysis and results that showed us that actually women who use Bissell services are more likely to retain housing than folks of other genders. And insights like that, which by the way is corroborated across other studies, which is really fascinating. But we can use insights like that to look at what are the strengths, what is the story behind those numbers, and to be able to push different levers and really make sure that there are better outcomes for everyone.
Thank you, Maria.
Yeah.
So there's several factors in respect to health with social determinants of health. Gena, a lot of value in social determinants of health. How can we weave that into public policy?
So the system is working the way the system has been designed. That's the position that we take. And so to give you some context for why I'm answering a question on public policy, because I'm not a government relations person, the work that Converge is doing is around how all the players are connected and how do we build more on and off ramps in the mental health system. So the mental health system is the only system that actually needs a Sherpa to get somebody through the system. When you break your arm, you know how to go get your arm fixed. But you actually need a systems navigator to get you through mental health to where you need to get to. The other thing that we learned over the last couple of years as we've been diving into this is that on average, doesn't matter what province you're in, it's the exact same across the country. People are bounced on average 6 times by the time they start their journey to the time they land, and it can go from 3 months to 5 years. So what happens in that time? Well, a few things, much to the social determinants of health. So there's obviously economic impacts to this because your productivity goes down, your caregiver's productivity goes down. As you get bounced, the acuteness of your mental health goes up, which means the cost to the tax system, to the healthcare system goes up. And then there's a whole bunch of social issues because as your mental health changes, you start to draw down on other social services, ultimately leading to some of the most expensive types of social services, which is shelter. And so we said, well, hold on a second, let's stop looking at the mental health space from a how do we get care to a how do we connect all the players and create those on and off ramps so that when you're going down the mental health highway, you actually can get where you need to go when you need to get there. So that's the context for answering this question. So as part of that, we looked at how policy actually creates those on and off ramps, or where do they put the potholes or the barriers in that highway? And one of the key problems is that we have 3 pieces of privacy legislation that are being interpreted differently depending on what hat you're wearing. And I heard a wow. That was also our reaction. But even more so, what we learned was that if you are a psychologist working in a nonprofit one day and in a private practice the next day, you can actually be in conflict with your college's interpretation of the privacy legislation. So imagine, so how can somebody actually take care of a patient if they can't actually figure out where they sit? And so what ends up happening is we don't want to share data because we're afraid we're going to be contravening the interpretation of the privacy legislation. So what we said was, let's bring all the players together and figure out how do we change the interpretation of privacy. And then can we make recommendations to government to allow for better system flow? And so that's the piece that Converge is really tackling now around public policy and how do you connect the dots between housing or getting access to park systems, which is also another interesting component of mental health, and your actual mental health care. So yeah, that's the role that policy plays, is kind of, they add barriers, but they can also be taken away.
Thank you, Gena. That leads to my next question, because there's policy, then there's also data. And when I was doing research, you find that a survey was sent out last year on Canadians and about sharing data, and that about 40% of the people are hesitant to share personal data. Now, the flip side of that is, I think we've all been into engaging the healthcare system, and we're tired of repeating our story. That's even within our organization or through navigating all the different organizations to help us when it comes to mental health. So, Danika, my normative is focused on female health. And Have you observed this hesitancy of sharing information, especially when it's that personal?
Yeah, absolutely. And I'll wait for the mic to catch up. You were doing a great job, sound guy. So I think there's some really famous examples that we can kind of pop into right out of the gate. There were menstrual cycle tracking softwares in the US that had in their terms and conditions that they promised that they wouldn't sell personally identifiable information, and then were found to be doing so. It caused a big uproar. They got sued, people moved, etc. And then we had other instances like the Dobbs decision that regardless of whether or not you felt secure and safe in the softwares that you're using and sharing and using to track your physical health and your emotional well-being, you can now have that data set subpoenaed and then used against you in legal proceedings, right? And so what that really called into question was a couple of things. So first and foremost, who do you trust with your data? What are the things that you want to see from an organization in place that will allow you to feel safe and comfortable providing information into the software that gives you the results that you're looking for to continue to use that piece of technology, but also be able to make those informed healthcare decisions or health decisions for yourself. And the other piece was kind of from an infrastructural lens, which is, do we need all of the data that we're actually collecting on people? So one of the things that MyNormative ran into, which is we collect a lot of personal health information, probably a little bit more than the average female health tracking software does, because we're really looking longer term at socioeconomic determinants of health, socio-behavioral determinants of health, genomic determinants of health, epigenetic ones. And so we collect a lot of health information there. And so then we kind of had this epiphany of how do we collect this data and still keep people safe so that if they had a miscarriage or if they were a high performance athlete and just didn't ovulate and didn't get their period, if our data was subpoenaed, how would it still feel safe for them? And so we had to go through and determine, and you and I were talking about this immediately before we got on the mics here, which is, what do I actually need to collect from you from a extra kind of layer of information that will keep you safely ID identified and keep you feeling structured while still providing the user experience that you've come to expect. So really, really easy example of this. So you clear blood lactate, the burning feeling in your muscles at different rates at different points in your menstrual cycle. This is going to feel so inane, but I promise it's important. And so one of the things that we do is we get rate of perceived exertion. How do you feel? How hard was that run? Where are you in your menstrual cycle? And in order to kind of understand the impacts that has on performance, because we have lots of high performance partnerships, we track how fast you run and how far you run, but we no longer track where you run. Right? Because then it doesn't matter if you're in small town Alberta or bigger city Alberta from a physiological perspective. And so if we have the data set subpoenaed, we can still keep you safe. That's one of the things that we really started to look at. And the question then from the user experience, and I'm still getting better at this, is how do you communicate that level of sophistication in your data planning and your data architecture and your data strategy to the users so that they then in turn feel safe with what they're providing you with.
Thank you. One of the key words you mentioned was trust, and I want to get back to that. But before, I want to ask Maria, at the Bissell Center, you work with low income and people with low income or the homeless community. Can you give an example where the exchange of information has been challenging, and how did your center solve that?
Oh, absolutely. It is very challenging. So, as you mentioned, we work with extremely vulnerable communities, and rightfully, we are very concerned with their confidentiality, with their safety, and so that's of utmost importance to us. At the same time, as Gena was saying, the legislation around privacy it's ridiculous, and especially in the nonprofit world as well. Like it's very gray. It's like extremely complex. You know, you need a lot of interpretation. You need like a Sherpa for it, and so needless to say, folks in organizations that are just trying to help people meet their needs and you know, make sure they have a roof over their head, diving into and interpreting privacy legislation and like technical security metrics is not on the top of their priority list. And so what that results in, oftentimes, is you just lock it down. You lock it down just to be safe, you silo it, and it's easier that way, just to lock it down. And I've even seen in some organizations, even colleagues don't want to share data with each other within one organization because we're not really sure what are the repercussions of that, but what are the rules around it. And this is really unfortunate because sharing data would actually allow us to coordinate resources better, to not duplicate services. It's also actually trauma-informed. Someone doesn't have to tell their story 5 times as they're being, ping-ponged around different services that aren't coordinated, So there's all these different benefits there to tap into. And one of the really exciting things that's happening right now with Health Cities is we're doing the Health Cities data warehouse, and I'm very honored to be a part of that work. So we have a few organizations coming together and sharing data together and using that to harvest joint learnings and to impact participants' lives. And so because data sharing is the whole point, looking into issues of privacy is very central to the project. Yes. Yeah. So anyways, it's exactly the kind of push that we need to look into that privacy legislation, to look into how we can keep data secure and release our information, free the information to make a bigger impact collectively.
Yeah. So it seems to me, we talked about the individual's consent to give data and collect only the right amount of data to be effective, how to exchange data within a system. And so it seems to me that our policies are not fit for purpose. Gena, can you comment on that?
Because one of the things that we don't measure is how much do these policies actually cost the system. So last year, the Alberta government put over $600 million into the mental health system, but we don't actually know how much. One second. The healthcare system is very active today. First responders, for sure. Yeah. So we don't actually know, of that $600 million, how much was lost due to these bad referrals, or these misdirected referrals, right? And because we don't know the cost to the system, there's very little incentive to change the system. So until we start measuring the cost associated with an administrator doing an intake, making a referral, another administrator doing an intake, making another referral, seeing a counselor saying, I'm not the right counselor, referring back maybe to the original referrer or maybe on to the next one. We actually don't know how much of that $600 million was spent on just bouncing people. And so one of the things we have to make in order to build these on and off ramps and change policy is we have to start putting dollars to it, because that's the one thing that government understands. And so part of why I'm fascinated with the work that these two women are doing is because you can actually start tracking some of the bounces that somebody is actually going through. So it used to be that we would say we have to do a journey map and we have to interview individuals and we have to get them to retell their story. Well, now we don't have to, because now we can go to organizations like this and say, help us figure out the journey of this type of population so that we can actually then apply the social metrics and the economic metrics to that population without actually having to re-traumatize people to get them to tell their story more. And that's the way that we're going to create that policy shift, is we have to tie the dollars to the actual shift that we want to see.
Thank you, Gena. And I want to dive deeper into how policy influenced our use of technology. And especially when we focus on technology and also on how it influences the creation of underserved and underrepresented populations in Canada. Danika, how does my normative, your solution, address this underrepresented population, which is women?
So there have been quite a few historical shifts through time. I think the original, does anyone else remember like Biology 101? Like the Vesalius guy who like used apes as a proxy for humanity, and we based a lot of our biological models off of that. And then from there we started digging up graves, and we had male bodies. And then from there we didn't really adapt a whole lot, and we ended up with a system that primarily operates off of the male body. And so what this does for us, obviously, is it means that the male is considered a sufficient proxy for the female body. And we scale the male body up, down, sideways, left, right, and center to behave as this adequate proxy for everyone else that could exist on the planet, which is obviously highly problematic in that if the male body does not go through these specific physiological states or physical changes, that those things aren't accurately represented, accounted for, and measured in the ways by which we collect, manage, and analyze information. And so my normative effectively is looking at changing how we understand what we call the reference man. So the reference man is the historical norm. It's a 70 kilogram, 20 to 30-year-old cisgendered white male. And with that, we have these really wonderful problems that come out of that are base algorithms and the ways by which you collect personal health information don't allow for you to not be that person. And so there are lots of really small nitty-gritty examples that I can give, but my favorite one, I recently had my first child, and while I was pregnant, I was trying to stay somewhat active, and I was going for a run, and my unnamed hardware of choice that tracks my runs told me that it was very concerned because I was getting fat and I was getting slow, and my heart rate was going through the roof, and that is because the base algorithms had no capacity for me to be pregnant. And so that is just a very obvious and simple example of the bias, which isn't like malintentioned at all. It's just this accidental thing that we bake into all of our tools, our methodologies, our algorithms that don't necessarily hold space for or account for the realities that we have. And until we have policy in place that kind of encourages us and forces us to be more representative and diverse in how we collect and manage information, we're going to continue to have somebody's watch calling them fat 5 months pregnant.
Thanks, Danika. Thanks for sharing that personal story, because I think sometimes it becomes so obvious when you're in it, and then you're compared to a reference point. But let's expand. I mean, that was an example for women. Maria, at the Bissell Center, you have there's several different groups. They have different challenges relating to poverty. And how is data used at the Bissell Center to advocate for those groups, especially with a diverse set of groups that you work with?
Absolutely, yes. So this makes me think of when we restructured how we collect demographic information, specifically around ethnicities. So over the past year, we've been meeting with representative working groups and talking about how can we collect demographic data in a way that will help meet people's needs. And that's what it ended up being, because when I asked our working groups, like, what is the most important function of the data that we're going to be collecting? What does it need to achieve? Why are we doing this? They all unanimously said, any data that we collect needs to help meet people's needs, right? And so that was a really powerful takeaway. So some examples of data that we collect that directly impacts folks of different populations. So maybe flagging when someone needs a newcomer So when a newcomer needs a translation service, or when different folks need help with status cards, or for example, helping reconnect someone to their community of origin. So all of those pieces of data directly impacts how we serve those communities. And then taking a step back, when we look at what we can do with the aggregate data, we can learn about where are the gaps in services, which groups are we serving more of, and are we not seeing the systems provide for. And then that way we can either adapt, make connections maybe with like a different agency that has different cultural supports, or we can also, again, advocate for those groups so that more of those services are available.
Thank you, Maria. It's fascinating how personal data can be empowering, depends on the lens, from a services perspective, from the individual perspective. As a patient advocate, and I don't like to use that term, but that's kind of the standard term, because I think you can either say all of us are patients, but at the end of the day, we want to be advocates for ourselves. And so with a group of us, I co-authored the Declaration of Personal Health Data Rights in Canada and Obligations. And this was in 2021. And one thing which we found when we circulated that declaration and internally was this debate between the rights to hold our data and then our obligations to provide data so services could be more effective, more efficient for the community and the people who we want to serve. And so we struggled between that balance. And so, Gena, Danika talked about trust, right? Trust in data, and that how policy can influence trust. So how can we improve that trust? And how do we come up with a pragmatic balance?
So, thanks, Mike. Trust is really subjective, and I think one of the biggest things, so in my company, Carmen Sense, we work with funders to help them do better philanthropy and align their impact investing. And I think part of the struggle that we have around the trust question is that, especially for community-based agencies, funders don't fund adequate data collection. Funders don't fund the overhead to manage data systems. Funders don't fund data scientists because that's not sexy. And so if we want to start building trust between all the players in the system, we actually have to recognize where are the gaps and how do we then build those safe bridge conversations. So when we started Converge has only been around for a year, but 2 years prior to it launching, we spent those 2 years building trust between tech companies, investors, nonprofit organizations, government representatives, and it was a lot of work. But that has now paid off, that allows us to have the conversations that we're having around shifting policy or getting the information that would normally be held behind a closed wall around economic evaluations. And so building trust is hard, it takes a long time, and it really requires a concerted effort from all the players to actually invest in it, which means that you don't see the return sometimes for, in Converge's case, almost 3 years. But man, once we did it, it's like going like gangbusters. So I did sort of an indirect answer to your question, as per usual.
Thank you, Gena. Let's fast forward 5 years in the future, and I want to understand is your view on how personal health data could empower individuals, what you see happening in 5 years' time, but more importantly is, can you give a comment of how you plan to get there from your lens. So maybe we'll start with Danika, and then we'll, yeah.
So maybe what I'll do is I'll build off of the trust and the policy angle that you were just discussing. So one of the really things that happened really recently was we did a review of the policies that came out in 1993 around sex and gender representativeness in the clinical sciences and in the life sciences. And we basically said, have these had an actual impact on how many female persons and women identifying persons we include in clinical and observational studies? And does it actually change how we do our analysis? And does it change health outcomes? So the really, maybe not fun fact, but the fun fact that comes out of it is although there was an ethical and regulatory requirement for more representative data collection, what we did in return is almost kind of spurn that trust, and we can see that fall out with our vaccine hesitant populations and that sort of thing, is we didn't actually analyze the data much differently at all to account for the variability that we saw in those populations with those increase in representative populations and more diverse populations. And so we forced outcomes to be the same and started just kind of labeling things as outliers instead of looking at how and why did we collect that data in a way that kind of facilitated the creation of those outliers. And so when we think about kind of in 5 years' time, and this is specifically from a minormative lens, what I would love to kind of see is I would love to see examples of what we saw with the COVID vaccine not happening again, where we had an equal opportunity illness for male and female persons that we then ran vaccine trials on. And then we all of a sudden had a lot of concern in menstruating populations around the impacts on the menstrual cycle, which we, of course, gaslit to the ends of the earth and said, oh, nothing's happening. And then we funded an NIH study afterwards in the US. And we're like, oh, no, that did impact things. But don't worry, just trust the next process. It will be fine. It didn't impact you. And then we also had specific vaccines get pulled off the market for perimenopausal and menopausal populations because, again, when we collected the data for this equal opportunity vaccine, we didn't actually analyze it in a way that would allow us how it would actually impact these significant subsections of the general population. And so for myself, for where I'd like to see my normative in the future, is I would love, right now, I mostly talk to people who study female health because those are the people who are ready to listen and have conversations around collecting personal health information in a way that will give us more accurate and representative results, but starting to kind of lean into those equal opportunity illnesses from dementia to diabetes to Alzheimer's to all these different arenas so that in the future we can understand that it is a strength to include really diverse socioeconomic information and sociobehavioral information and demographic information in our analyses and not just this extra step.
Yes.
That future me wants to be talking to everybody, not just the believers in female health.
Thank you, Danika. So in 5 years' time, I could see how, broaden the scope of the data set is actually going to be wiser in the long run than keeping it narrow in a specific profile. Maria?
If I were to dream, so my dream in 5 years' time, or sooner, if we can do it, would be for our community to have access, ownership, and control of their own information. Now, when you asked that question when we were talking earlier, it made me really nervous because at current state, the way that, the technology that we have right now, the databases that we have right now, that's not really possible. That would be very, very difficult to pull off and still be able to manage databases. However, just because it's not possible with current technology that we have doesn't mean that we should not strive for better and to think outside the box. That would be like the tail wagging the dog. We have to put our vision and our goals first. So, there's a lot of really interesting solutions that are being talked about. Like I've heard about blockchain technologies being used to give folks access and control of their information. And in general, I think technology is growing at a fast pace, and especially in the nonprofit sector, where historically we've been, just overall very underfunded, but especially in terms of evaluation, data, tech, innovation, like it is not sexy. You're so right, you nailed it. It's not sexy, so we have not really had a chance to catch up to, other sectors. We have not sexified it yet, exactly. But there is hope. So one thing that makes me really, really optimistic is, again, the Health Cities Data Warehouse, where we're looking at leveraging technology in order to have a collective impact, and we're putting the goals and the visions ahead of what exists today and what's available today in technology. So those are my hopes and dreams.
Maria, the Health Cities initiative, what geographic area is that? What's the footprint of that?
So, Edmonton.
Edmonton?
There are.
And where would you like to see that in 5 years' time?
The world. Well, hopefully Alberta, maybe Canada. I think if we could all come together and agree on the really critical data pieces that we want to track and the collective impact that we want to make, I think we could really have some powerful, really powerful impacts.
Yes, thank you. So I think the ambition is larger geographic area, Alberta, if not Canada, to have an impact. I think to get there, it's agreement into the data. Maybe that's going to go into my question to Gena. In 5 years' time, we talked about a diverse set of policies. What do you think would help things in 5 years' time?
So I think, so in the near term, I'd like to have our recommendations around how privacy legislation is actually drafted changed and adopt. So I hope that the government will adopt those recommendations. But at a bigger level, I really would like to see that funders, whether they're for-profit, corporate, private philanthropy, government, really understands the power of how their financial contributions are influencing the discussion. Because right now we're having a pretty binary conversation on how mental health is going to be managed in Alberta, right? It's a recovery-based model based on a very limited data set on one person's journey who has a megaphone right now. And the problem with having a single set conversation or a binary conversation is that it actually doesn't allow for all the players in the system to come to the table and form that trust. And so my hope is that in 5 years, we actually have a method that allows for these conversations to happen in a safe way, such that we're not having binary discussions around if safe consumption sites are good or bad, or if more rehab centers is what we need, because we don't actually know all the information that feeds into those binary conversations. We just know one data set that is pointing us in that direction. And so my hope is that we start to look at that, and most especially is that as funders into the charitable sector, we actually start to ask organizations the questions not about overhead or fundraising costs, but around how are you collecting, using, and evaluating the data that you have, and how can we help you actually get what you need out of the information you're collecting? Because if we can do that, then that information will feed back into the system, which will then feed back into policy. So pretty lofty, I think, but I think it's doable.
I think there's synergistic effects with what I've read. Canada has subscribed to a value-based healthcare system, which in essence is outcomes divided by the dollars. It's really going down to the individual and how effective it is for them. And there's a broader lens and looking at it from a money perspective. So it's great to hear the different perspective in terms of how do we provide value to individuals and to the community, either through policy or technology. I want to open this up to questions in the audience. And Daniel has a mic, so please.
Hi, Bob Schultz, Haskell School of Business. Hi, Danika. She was in San Francisco with our Hope Prize team about 7 years ago, something like that. Congratulations. Gena, I know from the things we did at Longview. And the winner over is right next to me over here for that competition. This is Calgary. This is the new network, right? We're getting back to where we used to be. So here's my questions. You're doing policy. Somehow you need an and solution because there already are solutions which are already here. So I'm going to go through like 4 or 5 of them that you may or may not know about, but these are the solutions that get to the next level beyond our current medical pay-for system of things that don't work. Okay, number 1, homelessness. 40–50% of people that are homeless are brain injured before they became homeless. So if you don't care for the brain injury, but the top rehab center in the world is in Calgary's Myosymmetries. And they've already done 3,000 ADD kids. The province never said thank you. Number 2, the pills. Glenda McQueen in her final speech said that it takes 6 people to treat to get one that works. It means that the pills for mental health were for maybe 16% on the gross side, but not the net. The net's probably negative. She eventually came to microbiome, but that's not in the normal medical side. That's more naturopathic. So we have to find some way to switch to what people are doing, that is finding pills that actually are supplements rather than the pills that don't work. Number 3, diabetes. So you have, if somebody has a diabetic foot, you chop the foot off. 73,000 chopped feet last year in the US. Orpix is already here. You don't have to chop the feet off, and if you don't, and Nanotest has the salves. Number 4, the senior falls. So we already have ways to monitor senior falls because the number 1 reason for seniors to be in emergency is falls. They have hip surgeries, they die quicker, whatever costs a lot of money. The technology is already here in Calgary, okay? And the last one is Indigenous. So you have more children under the care of Alberta Social Services now than ever were in residence schools, but nobody seems to know that. So my point is, there's solutions that are already here. If we can find some way to take your policy things and tie them up with solutions already here, we could actually be lead edge in the world pretty quickly because everybody else doesn't know what they're doing. So that's a question and an answer at the same time.
Dr. Bob, so one of the things about Converge, remember I said we started trying to build trust, is we wanted to start connecting those dots and really looking at like how do we amplify the work that Dr. Val Taylor is doing around microbiome and the brain-gut connection? Or why is it that when you look at ADHD drugs for kids, they're actually just microdoses of what you would give to an adult? And so one of the things that is special about Converge is that we have all these players sitting at the table together so that we can have a Branch Out Foundation and a Nimble Technology and a Dr. Val coming together to do a study that can then grow the business of Nimble, amplify the work of Branch Out's funding, and then get Dr. Val Taylor her extra research dollars. So that's exactly what everything that you've described in your 4 points of issue is exactly what we're talking about when we say we want to build those on and off ramps in the mental health system, because it's not the same for everybody. But if we know how the interconnected works, we can start to connect those dots. And I think because we have worked so hard to build trust with the government bureaucrats, they're listening to what's happening, because before they didn't want to listen to what was happening on the ground because it didn't feed their narrative. And so we now have the stories that feed a narrative that help them push their agendas through. And it doesn't matter what color party you belong to. So that's exactly it. We need to start looking at the interconnectedness of all these issues and amplifying the work that's happening here.
That's the word of the day, interconnected data.
More about interconnected, yeah.
Another question?
Good morning. Can you hear me fine? No?
Oh, can you speak up?
Okay. Yeah. Good morning. My name is Mirna. Just think of microRNA, and you can spell my name. Thank you so much for this conversation. Very interesting insights. We talked about all the positives of sharing data. what would be the worst case scenario if we shared all the data? What would happen then? What would be the actual heavy risk that the person is taking?
What is the heavy risk of sharing data? Danika, you want to?
Yeah, I mean, I think we touched on this a little bit in the conversation earlier, and I used the example of the Dobbs decision in the US, which is that we use people's personal health information, weaponize it against them, incarcerate them, create entire kind of populations of people that are hurt by their data. Other examples of this could absolutely include insurance problems and stuff like that. So when we think about what the worst case scenario is, it's certainly leveraging that data that we're collecting to do awful things, right? And I think this is why the conversation around what kind of personal information do we need to collect and at what level and for which populations, and how do we archetype that data so that it is safe and protected from all sorts of different stakeholders is really key to what we do at my normative, and I think also within the healthcare system writ large, right? It's part of why there are barriers as well as facilitators in having those privacy policies in place. And so I think if we're talking about, I mean, if the question is worst case scenario, the question is like the apocalypse and the devolvement of healthcare. But I think what's nice is that we clearly have a room full of thoughtful people who care about how we manage data. And as long as we are taking that approach where we have all of the stakeholders at the table, including the providers of data themselves, I think we should be in a pretty good shape.
Yeah. Thank you, Danika. It reminds me of almost all the other technologies that come out that's revolutionary, be it nuclear fission or even fire. But nuclear fission could be used to be destructive, or it could be used to be in a CT scan. So used properly. So we're still learning. Any other questions?
Another question. Do you think that Alberta as a system gives you a unique advantage compared to other provinces? So for example, in Alberta, we have Connect Care that is getting deployed, which allows all the health data to be connected, which is great for the conversation that we had today. So do you think that Alberta as a province gives you that unique edge compared to other provinces? And would that be the use case for other provinces?
So does Alberta have a unique edge? Who could?
I don't think we're unique at all. Albertans like to think we're unique. We're having the exact same problems that Quebec is having. We're having the exact same problems that PEI is having, right? PEI is a population of, I don't know, very small compared to Alberta. And they're having the exact same problem. So no, Connect Health does not give us an edge up on anything. It is another way of rebranding. I'm not even going to say anymore. We just spent all 3 years working on trust, and I just probably blew it.
It's a nice first step in terms of data democratization, making sure that if we call it the patient's file, the patient should certainly know what their file is and what it says. So I really appreciate that as a first step. I think the piece that maybe it needs to be built in order for it to actually be a competitive advantage is whether or not is assessing and intentionally providing opportunities within that for health literacy improvement and knowledge translation services, because if we're just chucking data at people, nothing particularly helpful can come from that unless you already have the tools with which you can interpret that data and then make empowered decisions with it. And so it could, in the future, with proper guidance, become a competitive advantage, but as it stands, I would not describe it as such.
Yeah, thank you. We have time for one more question. Oh, I think we have a gentleman behind us, Peter.
Fight over it, guys.
I'll take two. Deal. Okay, Mike? Yeah.
Just to build on what you were just talking about, Danika, and one thing that hasn't been addressed is education. And what is the role of education at all levels? And what data should people be thinking about at different points in time in their life to inform their decision making. And especially as it relates to mental health, my observation, having had significant mental health challenges over the last 10 years, is without mental health, physical health is very difficult because you can't make decisions related to physical health.
Thank you, Mike.
And I will move the mic back here.
Who would like to answer that question on?
No, I don't.
I think it's a really good question. I don't know that I have an answer for well, it's a really big question, dude. So I think when we think about the role of education in terms of different life stages, I mean, for me, the question starts from kind of a very young age in terms of how we start to teach people about their bodies and what they're going through and how to talk about their bodies. And I think public health and public health education plays a huge role there, and health literacy improvements overall. I don't specialize in the younger populations. One of the things that we do at My Normative, because that's the only thing I can really representatively discuss here, is making sure that when we provide opportunities for health literacy, A, they're on demand and relevant, and B, that they're provided in a way that kind of speaks to the general population where they are today and in that point, right? Per your point, if you're in the middle of a mental health crisis and it's like, hey, I noticed you haven't gone out for a walk lately, and I don't contextualize that for you and go, hey, looks like you might be having a hard time, it might be hard to do this. Did you know that 10 minutes outdoors can have a significant improvement in your mental health? If I don't give you that data and I just tell you to go for a walk, then it's not a super helpful piece of information. And so I think treating people as the intelligent whole people they are and always striving for context is kind of key, regardless of whether you are an advanced aged or super little. That's not a helpful answer, but that is the best answer I got.
In the context of Converge, we have a mental health and education pillar. And we're looking at that question from two perspectives. One is education in the education system. So whether it's direct to the kids or even professional development within the school system. And the other is education to the practitioners. And so there's a few things that are at play. One is schools don't actually have access to psychologists like they used to. So just before COVID, we cut the funding to school psychologists. And then we said to the individual schools, you have to apply for a grant to get a school psychologist back in the school. Right? So, and this is what happens when you have a healthcare system that isn't talking to the education system. And so part of what we're trying to navigate is how do you bring these two ministries together? And one of the best projects that has come out of these convergences is the funding for CASA, which is based in Edmonton, which are creating mental health classrooms. So literally embedding in the school mental health services that is coming out of the education system, not out of the healthcare system. And I think that the other piece to the whole education mental health question is really looking at doing something like what I think it's either Australia or New Zealand, and I can't remember on the fly. But whenever they set legislation, they actually look at it through a lens of mental health. So they ask the question: how does this impact the end user's mental health, mental wellness? And I think if we started to ask that question at the start of designing or implementing these rules, we would come up with different pathways to provide those services within education. It's messy.
Thank you, Gena. I think we have Peter.
Hi, everybody. So Peter Fenwick. I wear many hats. The hat that I'm wearing today is with my board hat for Imagine Citizens Network. I also declare an alignment of interest. Danika and I work together at My Normative. Some of you know me, some of you don't. But I'm going to, Shaneel, if I can tell, I'm going to say quickly, Gena, mandate letters. When every government starts, the Premier's office writes mandate letters. It's the mandate letter that breaks down barriers around the Westminster model of silo-based government. I think you also made the comment about the politician at the door and punting it to the broader public sector. Was that you? At the very beginning of the conversation?
Yeah.
Oh, so Shaneel had done that.
I commented on that Yeah.
All right, well, I'm going to direct both my questions to you, but I invite all the panel.
But I'm the moderator.
That's okay, buddy.
Yeah. it's
Closer
hard
to the
hear
mic. Kiss the microphone. All right, hi, thanks. Okay, short story. Good friend of mine works in the Ministry of Finance. He shortlists for a job. He happens to run the quantitative modeling unit. Basically deals with a shit ton of tax data. He's the two shortlisted candidates. This relates to the topic at hand. One's an accountant, the other's an economist. They both are given a problem to solve as part of the final stage of the interview. The accountant says, I can't possibly solve the problem. And the economist says, here's the solution. And they're both looking at each other because they know that they're the final two candidates. And the accountant looks at the economist confused. And then Mark, who's also an economist, looks at the accountant and says, why can't you solve the problem? And the accountant says, it would mean breaking the law. And the two economists look at each other and say, maybe you didn't pay attention to the name on the building that you walked into. It said Government, Ministry of Finance. We make the law. If it's not working, change it. Anytime a politician says it's part of the broader public sector's responsibility, they're not wrong, but they're walking away from their absolute social responsibility to represent the public in changing the law if it's not working. I think that's one of the key messages that I'm gleaning from your panel today, is that we all have a social responsibility to vote in the right party who will change the law to make outdated privacy and data collection things that are not citizen-oriented more citizen-oriented, to look at population health, not just sick care, and hiding behind false veils of past and outdated government documents. So that's my short story. My question, though, is, Shaneel, also, you made this comment, but you're being a bit provocative, and I think the panel didn't quite pick up on it, and I'm going to invite the panel to pick up on it. I think I heard you say Canada has adopted an approach to value-based care. Did I hear you say that correctly? I thought I was dreaming.
Oh,
I'd like to know if there's an evidence base that you can actually back and support that, please.
my comment at the end of the conversation was about that we should adopt value-based care. We should
Sorry, I didn't hear the word should. Okay, so could the panel, in the context of the topic, please describe what value-based care in a Canadian context would look like to better unlock the power of personal data?
That's a good question. You've been waiting to the end to ask that one, and so if I think for people, a value-based care is in essence, to simplify it as a formula, is patient-reported outcomes divided by the cost, and map that through the journey that they're going through from start to finish. And it really comes down to value. That's the definition. Any comment on Peter's question?
Has your brain ever turned to soup on a microphone before? I'm like, here's 13 different things. So there are a few things that I think about, especially from a normative lens. So one, we know that the diagnostic pathway, this is relevant to the conversations you've had around mental health. 7 to 10 years for female-specific illnesses, which is outrageous. The other piece that we look at is 70% or 80% of autoimmune disorders occur in female populations, and they're usually seen as outliers, right, in our populations. And so when we think about collecting and managing personal health information and data in a way that is representative and accurate, being able to be more effective and efficient with the data we collect, to track and account for patient-reported outcomes and the pieces that we see with it, hypothetically should have an impact in terms of how much it actually costs and the value that we actually deliver in terms of dollars spent to get people to diagnosis, to health equity, to health care. That's kind of my thought on that. What about you?
Great question. I almost wish we only had time for one more question.
Yeah.
Can we rewind time? In terms of value-based care, I mean, I hear the word costs, and I immediately, my thought is how much is this going to cost? What is the, what's the ROI? And in our sector, most of the costs are invisible. You see the bill for running a housing program, but you don't see the bill for having a population of folks experiencing houselessness. And not just the emergency services bill, not just first responders or the punitive system or what have you, like the actual human life, quality of life costs that incurs. I think definitely we need to think more deeply and broadly about what value means. I think the government has been taking kind of like a shortcut and looking only at the most apparent price tag, but I think it's definitely time that we look at it in a less easy but more accurate, more impactful way.
Thank you, Maria. Yeah.
So I sort of touched on this when I said, we don't know the cost of the system. So how much of that 600 million was lost to misdirected referrals? If we had a value-based system, we would actually know that number. We would know where to do an intervention sooner. We would know how to pivot or redirect somebody into a different direction. So in order to get there, we really have to make some hard, stop putting doctors at the center of the system and calling them a cost center. They're part of the solution. We have to start putting the users of the system at the center. And until we actually admit the fact that our system isn't designed for the user, our system is designed for the taxpayer and the doctors. No, and I'm not picking on doctors. I'm just saying, we've put the wrong people in the center of the value question. And so we have to stop looking at the solution as an expense and start looking at the negative cost to the system as the actual expense. Because then we can start designing the right way backwards.
To broaden the lens of when I look at value-based healthcare, it's a different way of looking at accountability. And there's actors in the system who are scared of that new way of looking at accountability.
Yeah, because people are afraid of losing their jobs.
Yeah.
And if you right-size the system, you may increase, but you may also decrease the net number that's inside a system.
Yeah.
And so...
Thank you. Well, I want to wrap up this portion of the Health Cities breakfast. I want to thank Danika, Maria, and Gena for your insights and wisdom. And also Danny and Reg and the Health Cities for facilitating this here in Calgary. And obviously the audience, thank you for being engaged. And I'm going to hand it off to Reg.
Thanks very much, Shaneel. Thanks very much, panelists. A really engaging conversation. So thank you so much for that. So just a few points before Danny does thank yous and wraps up. First and foremost, as you'll notice, the number of sirens went down during the half part. So Lisa called emergency services and said to keep it down. And so at least I'm impressed. Well done. Secondly, Peter, with that impassioned speech, are you going to run? I mean, because we think, you should run. Finally, I just want to give a special thank you to Bryce Lambert, who's come down from Edmonton to record this. he's going to do some magic on the sound to try to capture it. But if you could give a round of applause to Bryce for the work for this morning. Thank you. And Danny, over to you.
Yeah, thank you. Hello. Thank you everyone so much for coming. As I mentioned before, there is a survey on the back of these postcards here. If you'd like to fill it out, just scan the QR code. And just thank you again to this amazing panel. Can we just give them all a round of applause? We have the room till 10 o'clock, so if you have more burning questions, I'm sure you can approach one of the panelists. And yeah, thank you so much. Have a great day.